All right, good morning, everyone. We're just going to give it a few moments as people start filtering in from the waiting room. Thank you all for joining us today. All right, we'll get started. So thank you all for taking time out of your busy schedules to join Governor Mills's Opioid Response webinar series. I am Madison Barassa. I'm one of the SUD program managers here at the Office of Behavioral Health, working with the State Opioid Response Director, Gordon Smith. Gordon sends his appreciation for y'all being here today and will join us at the next webinar series. Today's topic is the Certified Community Behavioral Health Clinic model in Maine. Before we kick it over to that presentation, just wanted to take a minute to note a couple of events. Of course, the next webinar series will be held on June 7th from 11:30 to 12:30. Keep an eye out for the registration notice from AdCare to learn more about what that topic is for June. We hope you all have received the save the date for the Governor's 6th Annual Opioid Response Summit. That'll be held on July 25th in Auburn this year. It'll be at the Central Maine Community College campus. The focus will be creating a brighter future for individuals, families, and communities. Registration for the event will go live by June. One of the housekeeping items we just have today, if you do have any questions, please put those in the Q&A box at the bottom of the screen. The chat is also open. We just won't be monitoring the chat for any questions. So just use that Q&A box if you have any during that time. The team will answer questions at the end of the presentation, and we will get to as many questions as we can today. If we don't get to all of those, AdCare will post those questions and answers on the website in the upcoming weeks. I'm joined today by two really wonderful teams of professionals from the state of Maine. We have Sybil Mazerolle-McCray, who is the CCBHC Program Manager at the Office of Behavioral Health. And then we have Liz Remillard, the CCBHC Program Lead at the Office of MaineCare Services. From Kennebec Behavioral Health, that team, we are joined by Carla Stockdale, who's the Chief Clinical Officer. We also have Stacy Austin, the Recovery Coach Coordinator, Andy Heinzen, the CCBHC Project Manager, Pat McKenzie, the Chief Development Officer for Clinical Services, and last but not least, we have Carrie Ann Watson, the OHH Clinical Lead. So I will get this passed over to Liz.
Great, thank you, Madison. All right, so we're going to kick off our presentation today and describe to you what CCBHC is, what it stands for, and how we are designing a certified community behavioral health clinic model in Maine. And then you'll hear from our wonderful partners from Kennebec Behavioral Health on their efforts to implement a CCBHC model within Kennebec and Somerset counties, which is really exciting. So CCBHC is a federal model that started back in 2015 with the Federal Substance Abuse and Mental Health Administration launching a RFP, or request for proposals, for states to design this new integrated, coordinated mental health and substance use model. And since then, it has expanded across the country, which you'll hear a little bit more later in our presentation. But at its core, CCBHC is intended to coordinate mental health and substance use services across the lifespan. So it's available to anybody from birth to older age, regardless of their diagnosis, their ability to pay, and place of residence. So wherever they live, they're able to access these services at an organization that offers these coordinated mental health and substance use services. CCBHCs are person-centered and family-centered care, the services that are provided are driven by the needs of the community and by the clients that they are providing services to. Families are an integral part of the service delivery for CCBHC, especially when services are delivered to children and youth within the CCBHC setting. CCBHCs are intended to hold up evidence-based practices as a core delivery model for their CCBHC services for mental health and substance use care. And states have an opportunity to explore and require certain evidence-based practices that would be delivered within the CCBHC settings. And again, we'll talk a little bit more about that as we talk about Maine's model in a few minutes. CCBHCs are also intended to develop trauma-informed services, but also trauma-informed agencies and organizations. So looking at the way that they deliver care and the way that people experience being a part of their agency and being a part of the service delivery in a trauma-informed way. CCBHCs are also intended to partner within their communities. They're seen as a hub of mental health and substance use care, but also as a way to seek and support all the needs of the person that's receiving services from their agency. So looking at ways that they can connect with social service partners or primary care partners to ensure that the whole needs of a person are met when they're receiving care within their setting. So in Maine, we kicked off our initiative to support and stand up CCBHC model back in 2021 by establishing a 5-person cross DHHS or Department of Health and Human Services team. We have partners from the Office of MaineCare Services, which is where I am, the Office of Behavioral Health, and then more specifically within Children's Behavioral Health Services as well. For the first few years, we've been working on the planning and design of our CCBHC model, and just recently began to look at how we are going to implement that model in Maine. And we currently have a CCBHC planning grant through the federal government to do that. And Sybil will talk a little bit more about the demonstration that SAMHSA has put out for states to be a part of. And that is hopefully where Maine will be able to take our CCBHC efforts and participate in this demonstration of CCBHCs in Maine and be able to implement the clinics and stand-up clinics across the state. Once we do that in 2024, so hopefully this year, we will look to expanding and implementing and improving upon our CCBHC model. So I gave you a high-level overview of what CCBHC is from the intention of the model, but specifically CCBHCs receive a different payment structure for the care that they provide. There is a daily or monthly rate for the people that they provide services to. That's specifically for people who have MaineCare. However, that rate is designed, or the payment for those services is designed based on the cost to provide care to all the people that they serve, regardless of insurance type, regardless of no insurance at all. And it's really looking at the cost to provide care to the people that they see. And that's rolled up into one rate or one payment that then is applied every time that they provide care to a person. In Maine, we are looking at providing a monthly rate for our CCBHC model. And that monthly rate will encompass the services that you can see in this, this pretty visual here with all the bubbles. And these are the required services of the federal model that we have been able to look into deeper and define what that would look like and what services would be provided within these bubbles in Maine. So for CCBHC, there's also 6 criteria that the organizations will need to meet to be able to be designated or certified as a CCBHC. They have to have staffing structures that meet a team-based approach to care, that meet the co-occurring capable requirements of being a CCBHC. And what that means is that there are staff that are able to treat both mental health and substance use needs, but also other social health and care coordination needs of the people that they're serving. There are availability and accessibility standards of care for CCBHCs, and I'll talk about that in a few slides. Care coordination is the foundation of the CCBHC model. And we often hear that word get thrown around, care coordination is like case management, which is true. But from the CCBHC perspective, care coordination is a foundational activity that is provided throughout any service that's offered to a person. It's the way of supporting the needs, even if you're receiving just a clinical service from a CCBHC, that care coordination is also a part of what you're receiving when you're getting maybe just therapy at a CCBHC. They'll be able to help coordinate and outreach to other care providers that may be in your circle of care. We do have a clear scope of services that are required for CCBHCs, as I had mentioned just a few seconds ago. And in these bubbles, there are some kind of overarching elements that are expectations of service delivery, person-centered and family-centered care, that services are delivered in accordance to the requirements for serving service members and veterans, and that screening and assessments and diagnostic services are provided, and the treatment and the treatment planning and the implementation of that treatment plan are person-centered, are focused on person-centered and family-centered values. And then when we think about service delivery, there are 6 or 7 key services. I can't do the math in my head right now as I just named these, but we have crisis services, we have outpatient mental health and substance use services, which is like medication management or therapy, as I'd mentioned. We have targeted case management services. And in CCBHC language, we call those just case management services, not to confuse how we look at Maine's model of case management services. There's psychiatric rehabilitation services offered within these organizations, and peer support and recovery services offered to people who are receiving care at CCBHCs. And then the 2 additional requirements or criteria that CCBHCs must offer is the being able to measure and improve upon the services that they are delivering. So there are specific quality measures that CCBHCs must report on and then improve upon as they are looking at the data of the care that they're providing. And then additionally, they also must have organizational structures that are looking at how they're providing services to the people that are a part of their service delivery structures. So for CCBHCs, their governance board must have 51% of people with lived experience serving a part of that board, or have meaningful engagement with people with lived experience providing input into that board structure. So I'd mentioned that partnerships were important, especially as it relates to the care coordination aspect of CCBHC. And what we wanted to provide here was the visual of what that coordination of care can look like for a CCBHC and what it may look like for a person receiving services. So as a person is receiving services from a CCBHC or being cared for by a CCBHC, the CCBHC and the staff that work within there are intended to reach out and coordinate and collaborate with all of these other entities that are maybe interacting with that person's mental health and substance use care or otherwise to support that person in that journey of recovery and support. And so, as I had mentioned previously, there are standards for access and availability for CCBHCs. The way that somebody would interact with the CCBHC, if they haven't already, if they're a new person engaging with the CCBHC, is through a initial screening process. And that's supposed to be brief and supportive in thinking about what is that person's needs. It's supposed to be a very quick check-in on what is it that they need for care, why are they presenting, and how quickly do they need to access the services that they're presenting for. And so there are 3 ways of filtering the needs for individuals receiving care within a CCBHC, or seeking care rather. There's crisis, urgent, and routine. And so people in crisis get immediate access to the crisis care that's accessible in their community, whether that's through the CCBHC and a mobile crisis team, or accessing support right there on site through a walk-in support. From the crisis care, there's follow-up that can happen within the CCBHC to support longer term needs that person may have. Urgent need is that if a person presents at a CCBHC or calls because they have a need and they're not quite sure what that is, that may present as an urgent need, and that person is intended to access a CCBHC service or care from a CCBHC staff member within 1 day. Routine needs are put into kind of the longer bucket, where if somebody may be calling or presenting at a CCBHC, that they would get access within 10 days. And that is that's for I think a larger group of people who may be calling but don't have that need to see somebody today or tomorrow to meet the needs. However, CCBHCs will build in processes and ways to access staff within their agencies to be able to have that. I know KBH will talk a little bit about how they're working on the processes to meet these access of care standards.
Great, thank you, Liz. Also, Esther, I did see your question in the chat and I accidentally replied to host and panelists only. But just to let you know, CCBHCs have the flexibility to meet youth in schools as needed, but the services or a CCBHC must be a licensed behavioral health provider. Just letting you know that. So at the federal level, there have been parallel tracks of funding to really encourage CCBHC implementation, one of which is clinic-specific SAMHSA grants. We have been working with 6 SAMHSA CCBHC clinic grantees in Maine to help us develop a robust and feasible CCBHC model for the state. Those providers are Ristic Mental Health Center, Community Health and Counseling Services, Kennebec Behavioral Health, Maine Behavioral Health Care, Spurwink, and then Sweetser as well. Can you go to the next slide? The other funding track is really the ability to participate in SAMHSA's demonstration, Liz had mentioned. And as you see on this slide, there are only 12 states that have actually implemented CCBHC with the reimbursement mechanism required for the type of services that they're providing. Implementation of CCBHC at the state level is a trigger point for the transformation that then comes once you have a reimbursement structure that really covers the cost of providing the care that a CCBHC needs to provide. I think it's important to note as well that Maine shows up as light blue because we were awarded a SAMHSA planning grant. Last year, we found out that we were awarded. That opens the door for us to be able to apply and participate in the federal demonstration. This federal demonstration is, you could actually, you could implement it through a SPA and or a Medicaid waiver, but we chose to pursue the demonstration because there is an enhanced federal match on the Medicaid reimbursement. So it gives us a higher federal match rate, which is beneficial to the state. And I do want to say that we did submit our application to the demonstration at the end of March this year. So March 20th, we submitted that application. We will be hearing back about mid-June about whether or not Maine has been accepted to participate. Liz, can you go to the next slide? But that demonstration grant was quite the lift for our CCBHC department team. There were 7 different attachments, a 30-page program narrative about Maine's model, and the way that we've gone about developing the prospective payment system process. Some of the highlights from our application, we had to select some goals for CCBHC, which was really provide the most complete scope of services to the Medicaid population, but more broadly, how to improve availability and accessibility to outpatient mental health treatment for all. And there were some populations of focus that really align with some other efforts that are occurring in the state right now. Our special populations underneath that umbrella of individuals with serious mental illness, serious emotional disturbance, or substance use disorder. We also had the duly diagnosed individuals, youth and adult, that have IDD and behavioral health challenges. This is to align with some of the work that ODS is doing right now to increase outpatient behavioral health access for individuals that they serve. We also included justice-involved youth and adults, as well as service members and veterans. And we also got a chance and the opportunity to talk more about our process to receive Maine stakeholder feedback as we were developing the model. If you take a look at the map here, the CCBHCs that were named as part of our application as our partner, soon to be CCBHCs, will in fact eventually cover at least 10 counties in Maine, and that will spread as we add organizations into the demonstration. If you go to the next slide. So CCBHCs are required to provide evidence-based services States do have the flexibility to require specific evidence-based practices that all CCBHCs must offer, but it also adds some flexibility for them to offer EBPs that really are going to be transformational for the communities that they serve. So it's based on the community's needs. The required EBPs for Maine's model is medications for opioid use disorder. And for youth, a provider can choose to either offer adolescent community reinforcement approach, or they can do the multidimensional family therapy. But other allowable evidence-based practices that we have highlighted with our partners or to our partners is contingency management for stimulant use, intensive outpatient treatment, ambulatory withdrawal management, and then also we added in one for traumatic loss support. So for example, an individual that has experienced a loss of a loved one due to overdose, we have highlighted the prolonged grief disorder treatment, EBP. Next slide. So CCBHCs, as Liz talked about, are very co-occurring. You can expect the substance use type services that you are traditionally familiar with when it comes to substance use treatment. So obviously MOUD, medications for opioid use disorder. CCBHCs must also adhere to the core standards of an opioid health home, that's soon to be SUD health home. There's the case management components, outpatient therapy, as Liz had mentioned. But the primary diagnosis of substance use doesn't drive your treatment. And I think that that's really important to understand. You can get both your substance use and your mental health addressed at the same time within a CCBHC. And sometimes that has been a barrier in the past where that primary diagnosis is really the driver of your care. So CCBHCs do that person-centered treatment planning for all of the behavioral health needs of that individual. It must be co-occurring. They have to be a tier 2 naloxone provider with the state, and they must make connections to opioid treatment programs. So they have to have a care coordination agreement with a local OTP for individuals where methadone is the most appropriate treatment medication. Now, if there is that opportunity for person choice in your care. So if somebody is already connected to a substance use treatment provider and they're receiving their substance use treatment at a different organization, they can maintain that provider and continue on that care, but also access some of the other services that a CCBHC offers that maybe their substance use treatment provider does not. And when in that case, a CCBHC would have to collaborate, coordinate, and communicate with their substance use treatment provider. Next slide. So there are opportunities to learn more about CCBHCs and to have feedback in the design of the model. We host bi-monthly public stakeholder sessions that you can participate in. And these sessions we typically facilitate, the next one being May 20th. You can sign up to register. I believe that link would be active in the slides that Lorena sent out, but I will put the registration link in the chat. And then there's also an opportunity for consumers of behavioral health services to connect with our peer policy manager, Mindy Smith. They host quarterly CCBHC information and feedback sessions. And the next session for her will be May 22nd. So just email if you want to participate in that. And then next slide. Further questions about CCBHC at the state level, you can send them to ccbhc_DHHS@maine.gov. And now I have an opportunity to turn it over to one of our CCBHC partners, KBH, to talk about some of their current efforts and some of their future opportunities once Maine rolls out the model officially.
So thank you, Sybil. Thank you, Liz. And what we'll do, I'll just talk a little bit about first the overview of what CCBHC means for us at Kennebec Behavioral Health, and then our team that works in our opioid health homes program and our substance use programs will focus more specifically on what we're doing in those areas. So if you could go to the next slide. So for us as a provider and for the other agencies in the state that are working on CCBHC, it is truly transformative. And even though we've been working on this for close to 3 years now, we are just at the beginning of understanding what that transformation could mean for all of us, I think, because it is so significant. And the shift, as Sybil mentioned, from the fee-for-service payment to a value-based payment system with the monthly payments based on the agency's actual costs is a big shift in the way behavioral health is envisioned and delivered. And so for all of the CCBHCs, you're required to drive that from a community needs assessment, which is the first step. And so our community needs assessment that we did, we reviewed more than 25 different primary sources on demographics, economics, health status, behavioral health status for both Kennebec and Somerset counties and then statewide. It was also informed by community sources such as the Maine Shared Community Health Needs Assessment, Kennebec Valley Community Action Program Community Needs Assessment, and our own consumer survey. In this case, in the survey that drove our initial assessment, we had 799 consumer responses to our annual survey. So all of that information feeds into identifying what are the needs in our community, and that becomes the driver for how each agency that's becoming a CCBHC designs how they want to provide services and the areas that they want to focus on, how they want to staff up to be able to do this. So as Sybil mentioned, or I think as Liz covered in the initial model, there is the comprehensive service array that you're required to provide as a CCBHC, which includes 24/7 crisis services. And in our case, we partner with Crisis and Counseling Services in Augusta as our crisis provider for the crisis services. So the care coordination is a big piece, and we'll also get into that a little bit more. That is what happens right out of the gate when someone comes into services. They're hooked up with a care coordinator who works with them. And then we've established and are still establishing clinical pathways from that intake and the care coordination for people to move into the treatment programs that they want to receive services in. And then expansion of evidence-based practices, which we will talk in today's presentation specifically about the co-occurring evidence-based practices that we use. But we have at KBH a suite of several different evidence-based practices that we utilize, including the ones that you will hear about today, but many others, including trauma-focused cognitive behavioral therapy, multi-systems therapy, dialectical behavioral therapy, parent-child interactive therapy, different evidence-based practices that different clinicians at our agency offer to folks across the lifespan. And we'll also be moving into eye movement desensitization and reprocessing, which is a mouthful, EMDR, which is recognized as an efficacious trauma therapy. And so we are beginning training for staff on that. So that's a big lift to do a lot of the training and development of evidence-based practices, and a lot of credit for the work that's happened here at KBH does go to Pat McKenzie, who you'll hear from a little bit later on developing our capacity in that area. Strengthening, expanding partnerships. I think that was focused on a little bit, and the community partnerships is really integral to the CCBHC model. Nothing happens in a bubble in the behavioral health world, and CCBHC really explicitly is intended to encourage agencies to build care coordination agreements, memorandums of understanding, clinical protocols with partners in the community to provide the supports and resources and care teams that people need outside the walls of the clinic. Implementing quality improvement, I'll connect that one back to the last bullet here, which is evaluate. Those two things are key, and as a CCBHC, you're required to have an evaluator, which could be a staff position or it could be a consultant. In our case, it's the consulting firm Heart Communications in Gardner, Heart Consulting in Gardner, and they provide our evaluation. As we look at our data, as we identify ways that we can improve things in our CCBHC, changes that we want to make, look at ways that we see opportunity for improvement. That's a big piece, and that's an ongoing quality improvement work that happens as a CCBHC. The funding and payment mechanisms is the transition to that monthly rate. In the case of Maine, Maine is going to implement a monthly payment rate. And so each CCBHC will have a rate that's set based on their costs. So we all submit our costs individually in a cost report, and then we have a monthly rate that covers those costs so that we can focus on what we need to provide the services, receive a monthly payment, as opposed to billing a fee-for-service model, which we have typically done for most services up till now. And then recruiting and training staff, which is a big issue for all of us in Maine and really across the country. Behavioral health agencies face workforce shortages and really have challenges in finding people and filling positions and developing retention within the agency. So that is a big focus for us too going forward, because as a CCBHC, we already have added several staff and have plans to add many more staff. So getting those positions staffed and getting folks trained and having the capacity to provide the services is really key. Nothing happens without the people to be able to provide the services. So if we go to the next slide, I'll hand this over to Carla Stockdale, who's our Chief Clinical Officer, and she will walk you through our access changes that we've made as CCBHC.
Thank you, Andy. So good afternoon. I'm going to be quick and then going to hand this off to our team. But one of the biggest things that we had to wrap our arms around as an organization about CCBHC is that it's not a specific program or service. It's really a model of how to deliver whole person care regardless of the person's location or ability to pay, with, as we noted, a funding mechanism to support the costs of doing that. And as a result, a big part of our CCBHC development, which was through SAMHSA grants at this point, was focused on how and when we brought people seeking services into care. As part of our grant, we identified priority populations to be enrolled in the CCBHC based on our community needs assessment, as Andy noted. Some of those were veterans and military connected individuals and families, LGBTQ youth, individuals who've been involved with the criminal justice system, pregnant women with using substances, and additionally, we had some other individuals who were unhoused, individuals that did not meet the qualifications of our outreach services. So as a part of us bringing folks in, we added screenings and care coordination to our Access Center to assist with getting client needs met and connecting them with resources while they were waiting for services and getting them to the right services. We implemented an expert approach to screening and intervention planning. And at the first call to KBH, clients receive a risk screening that takes place with the individual on the phone utilizing the Columbia Risk Assessment for adults and the ASQ for children. And then we triage with crisis services accordingly if needed. And as we begin CCBHC enrollment, additional screenings take place that build on the full psychosocial and inform the care plan. So as you can see here, the screenings we use are the audit tool, the ACOK, the 5 A's for tobacco use, PHQ-9 and PHQ-9A. And then, as we said, other developmental risk assessment tools. And as Andy said, care coordination begins at first contact. Next slide, please. So our approach in the CCBHC is that care coordination is really everyone's business. And as we mentioned, it's just not an activity for some folks. And then we actually have our own department. The CCBHC model requires and provides funding for us to employ staff who are dedicated care coordinators for all individuals enrolled in our current CCBHC, and we'll do so going forward with the funding mechanism. This is the exception is those who meet targeted case management services at more intensive level of care. Those individuals would be the lead care coordinators for those individuals in that service. So with long wait lists and staffing shortages for behavioral health services everywhere, KBH has been no different. We have a significant wait time for our clinic-based services, particularly outpatient and medication management. And as a result, our Access Center has built KBH's Care Coordination Department, where care coordination begins at the front door, as we call it, where they provide person-centered care coordination that includes care planning, communication, coordination, and collaboration, the big C's, linkage and referral with warm connections, follow-up and monitoring, and advocacy and support. And this is really helping connecting not just to services, but any of those community needs, and also staying just connected with that individual as their kind of their process all the way through KBH. Next slide, please. And as we mentioned, evidence-based practices are a really big part of the CCBH model of care delivery. And so part of that is providing effective age-appropriate services across the lifespan. We focused on developing and expanding our infrastructure and capacity to provide evidence-based practices for individuals and families affected by substance use and co-occurring disorders. So OHH and medication-assisted treatment, our medication-first approach, is certainly one of our evidence-based practices. And within that, we are providing attachment behavioral catch-up, which is an evidence-based practice. It's a mouthful, EBPs, for pregnant women and new parents. And then we also have an EB approach within our OHH to individuals and group therapy. Then along our continuum, there are also evidence-based practices provided within our outpatient setting as well. We provide CRAFT, ACRA, Adolescent Community Reinforcement Approach. This is one thing that we brought into for training, particularly for our school-based clinicians that are in those school settings with the adolescents. We've trained in ACT and MI, that's the acceptance commitment therapy. And then of course, you'll be hearing more about our recovery coaching. We also have expanded evidence-based practices, as Andy noted, to meet the needs of children and families we serve. And that's including trauma-focused CBT and MATCH. Our expansion of the EBPs, we provide included clinical training, supporting the clinical staff to obtaining required certification, ongoing supervision, consultation, and monitoring fidelity and outcomes. So in addition to those screenings, care coordination, and the expansion of EBPs, we're going to spend some time sharing more of what's happening in the programs. Next slide, I'm going to hand it off to Pat, please.
Thank you, Carla. Thank you very much. And Carrie Ann did have to leave. She is meeting with a client that really needed to be seen now. And so she's trusted me in her notes. So I hope I do a really good job. And Stacy Austin will be assisting me. So we'll be sharing some slides and getting through these. So increased access to care and recovery support for individuals with substance use disorder and co-occurring disorder have been a major thrust. Actually, the OHH is so neatly aligned with so many of the aspects of what a CCBHC standards are that we found in our OHH that it really enhanced our capacity in many ways to think outside the box and to really develop our OHH as a, certified community mental health center, behavioral health center. So we're going to talk a little bit about that rapid access to our OHH. We do provide a holistic and person-centered service within an integrated team, like most of you there, if you're other OHH family out there. And we've really expanded our access to be kind of increasing engagement in the community that is involved in our OHH and may potentially be involved through expressive and horticultural therapies. We work very closely in our community with the Bridge program at Reddington Fairview General Hospital, which is a rapid access to Suboxone treatment anytime 24/7. And we seamlessly bring people in from that program. And actually about 85% of our individuals in our OHH have been a member of the Bridge program at Reddington Fairview General Hospital. That partnership, we'll talk a little bit more later about that. I'm going to ask Stacy to talk a little bit about our recovery coaching center that we have that's highly integrated with our practice at the OHH.
Thank you, Pat. The Recovery Coaching Center is a place where our recovery coaches that are trained through the CCAR model, which uses the approach of using individuals as resources rather than recipients. So the Recovery Coaching Center is a place where you can connect with the community, resources, and with others to build upon your recovery capital. It's the hub of the recovery community in Somerset County. And at the center, we have space to support group meetings that are open to all pathways of recovery. We have trainings and resources to help with intellectual growth, have opportunities to have fun and create healthy social connections, such as our paint day. And then we build on occupational wellness and discovering resources and avenues that you may want to pursue by using our computers in our resource room or talking with a coach. You know, it's a safe place where you can come, grow, and imagine what your future in recovery can be about.
Yeah, and how we've accentuated this partnership is that, as you know, the OHH has in their a key member of their interdisciplinary team are recovery coaches. We've worked closely with Stacy in the community world to continue to provide coacher vision, consultation with us, and helping to support our recovery coaches who are working on the ground as part of our interdisciplinary team in our OHH, and hope to expand recovery coaching across the CCBHC wherever it is needed, along with our intentional peer support folks. ROAR, and Stacy's going to talk a little bit about ROAR, but ROAR was actually kind of an organization or a group of concerned folks about 7 or 8 years ago that we established as we started to move to try to expand treatment services and to expand recovery supports in Somerset County. And Stacy, you want to talk a little bit about ROAR, because you have taken that over and done a great job of expanding it.
I mean, ROAR meets once a month at a monthly meeting, but it is a peer-run group championing those in recovery. We're a group of people that empower others and support others in recovery. People that are members of this group identify as a person in recovery, a recovery ally, or an affected other. So we're there to support other people, reduce stigma, and we're there to promote resources by sharing at community events and being positive examples. Some of the community events that we take part in are National Night Out, Skowpendus, which is a huge community event here in Skowhegan over the last weekend. 5K runs, overdose awareness, and in the month of September, we even have a huge recovery rally that we hold here in Coburn Park that all people from all over the state of Maine join in and celebrate recovery.
Thanks, Stacy. We added Project Recovery because for us in the OHH, we found that recovery begins from the moment we meet with you, the possibilities of it, and then the journey through your own chosen pathway through recovery. And we decided that that's pretty important under the CCBHC model that we're working our OHH in to really make sure we're community integrated and really thinking of the, wellness and recovery throughout everything we do, not separating treatment, but integrating treatment into that process too. One of the projects we have in Kennebec County that we do hope to bring here to Somerset County with the OHH is a project called Project Recovery. And this is at the other end of engaging individuals, connecting through outreach to get people, if they, whatever they want to do in their journey, their pathway, but connect them to the treatment of their choice, the recovery services of their choice. So Project Recovery is something we really hope to be expanding here in Somerset. It is right now just Augusta, but it's working with our emergency medical services and other first responders, doing outreach to those who are at risk for an overdose, or just those who are perhaps in need and don't quite know how to get going and get started in treatment or recovery supports and/or. We can go, I think, to the next slide. So a lot of the work in Somerset County for us at our OHH is really about our community partnerships. We work very closely with Somerset Public Health, the Skowhegan Police Department, Somerset County Sheriff's Department, and as we said, a huge amount of work in coordinating services across Reddington Fairview Hospital and the primary care settings in our community. This network development is critical in our work to really enhance, you know, the outcomes that we're seeking, having people stay in treatment, being able to benefit from treatment and get their family, friends, and themselves the supports to meet their basic needs and enhance their wellness in the community. I would ask maybe Stacy, you can share some examples of how that work has, how we've integrated our OHH treatment, our CCBHC efforts, and the work you're doing in this building of community network.
So we work with the OHH, the Recovery Coaching Program, the ROAR program, the Recovery Coaching Center. We connect with Somerset Public Health and other area resources to work together towards a common goal. So we utilize each other's strengths, support each other's programs, and by doing so only increases the impact that we make on the community. So it's like we work together to support Somerset Public Health's community connections that are in Madison and Bingham. So we'll send recovery coaches there, or she'll send referrals to us. We work with the Somerset County Jail to help residents during their incarceration. So we help connect them to community resources upon their reentry to have a more successful outcome. So when they get out, they have those connections to the resources already in place. That could be treatment, that could be getting a recovery coach, that could be just connecting with the communities that they live in. We've also worked with collaboration with the Skowhegan Police Department, doing ride-alongs in the area, connecting with places and areas and neighborhoods where there's been overdoses. And here we connect with people with naloxone training. We provide naloxone, we provide community resources, and we just try to get to the word out of the whole neighborhood and the communities about what resources are available through our community.
Yeah, so I would wrap that up as saying is that Stacy's work with the law enforcement has allowed us a really unique opportunity to do rapid access to our OHH through this work, where we can reach out after maybe Stacy and police or EMS have reached out to somebody. We can reach out because they reach out to us and offer some, either some, connection to treatment, or even what we'll offer is we will meet you in your home and start to discuss the possibilities of withdrawal management there in your home if you're really uncomfortable in stepping forward. There's many people that share they've had negative experiences in the past with treatment. So we're really trying to meet people, as Carrie Ann would say, where they are and where they're at and where they're most comfortable. That's our kind of future challenges, one of our future challenges that Carla is going to talk about in the next slide. I'm going to turn it over to her.
So what's next for us? So the grants that we currently have provided many opportunities to ensure that we have foundations for the model of care, and also integrating, as Pat and Stacey have demonstrated, how can we integrate current work that we're doing into the umbrella of the CCBHC model to be able to expand. But having the opportunity to become a CCBHC with the state of Maine with full certification and prospective payment system in place, it's going to not only require us what is required to do, if you've seen for those required services, but allow us to do so much more with our service delivery model. And we're planning as part of that, moving ahead, more training to increase co-occurring capable competency and capacity. As we talked about, we have partnerships already, but this is really formal care coordination agreements of how we work together with methadone clinics and addiction specialty care. Expansion of MAT into Kennebec County, as we are required to have MAT in a CCBHC, and we'll be having a CCBHC in both Kennebec and Somerset County. Transformation of the opioid health home into the SUD home, advancing contingency management, treatment, and community-based withdrawal management. And then we're also in a pilot project with brain injury screening with ODES and Brain Injury Association of doing brain injury screening and connections for individuals who have overdosed. And they'll be doing that, piloting that in our OHH. And that brings us to a close. So final slide of the presenters, Liz, and then we'll turn it over. Thank you.
So at this point, I'd be happy to open it up for additional questions. I know we've answered a couple in the chat, but this was a lot of information. So if you do have any questions, please let us know. In the Q&A box, as Madison has specified. Madison, I'm not seeing any populate.
Yeah, if you want to, there were a couple of the questions that were answered in the chat. Maybe you want to just go over those just for folks that don't maybe have access to the Q&A box. Just say those ones live. I think you had answered one from a couple from Ben in the chat in the Q&A.
Yeah, so Ben, just as an FYI, that the SAMHSA demonstration is really for the states to apply as a statewide entity in order to be able to reimburse with that prospective payment system. And then I know that there had been a question about services being provided in schools. Esther, I don't know if you wanted to elaborate a little bit more on that, but I think, you know, we have seen some of our SAMHSA-funded CCBHCs collaborate very well with schools in their areas, and we're happy to provide further information about that. And Liz, I did see there are a couple. One from Carolyn Raymond. How do you handle meeting the 10 requirements when you have wait lists for new patients? And I'll hand that one over to KBH.
I'd also bring to Pat, she's working with our Access Center as well. So the 10 requirements really are once folks are coming into service. We're working on implementing a more rapid access model, but right now we're straddling a fee-for-service payment system and trying to plan for a prospective payment system. So having that ability for open slots, so to speak, things like that right now are really challenging, but we're doing all the groundwork. So right now we're really doing all our screenings and you know, assessments and getting ready to people, and then we're triaging at the front end. So anything to add, Pat, to that?
No, just that we do have to, the wait lists are long. We all know, I mean, Carolyn, you know this too. It's like wait lists are long and it's really hard to hire. But I really think the care coordination service has improved, even though we're not where we want to be with everything. Having care coordination at the front end that follows you, that does a plan with you and recontacts you, or you can recontact us at intervals that work for you as you do wait for services. We can also connect people to many of the other services. It's possible to connect people to recovery coaches, to peers, before we actually get them in the seat of you know, for their treatment, say an outpatient treatment, particularly. In our OHH, it is really pretty rapid. People aren't waiting there. We just move pretty quickly. And if we can't do it, we have such great relationships with other providers who provide OHH services. We work very closely with them. But I can't tell you how much improvement we've had because of having care coordination for people on wait lists. It's amazing. You can get so much done in that time, many times. So it'll be better when we don't have a wait list, but we're not there yet.
We're also, the evidence-based practices is they're getting, right, you're going to have the goal, right, is to have better outcomes sooner as you're working with folks too, to help move folks through some of those clinic-based settings, specifically for your outpatient school-based as well. So to see folks kind of moving and then being able to come back as needed to treatment.
Liz, there was a question in the chat summarizing how the payment model works. Is that something that you want to talk quickly about?
Absolutely. So as mentioned before, and I think Andy, you helped hit this home for how Kennebec Behavioral Health will be doing this in all CCBHCs that eventually will be adopted at the state certification level. So the cost for a CCBHC, so much like other rate development happens, there is a cost report that a CCBHC organization would be filling out for all the services that are required of the CCBHC to deliver, and then any allowable services that they will also incorporate. The cost report encompasses the cost of care to provide those services, not just to people who have MaineCare, but to everybody that they see and provide those services to. And then that costs, all of those costs roll up into a per month rate based on the number of visits that the agency has actually seen over the last year. So it's a year perspective for the cost report. And that produces a monthly clinic rate. For CCBHC, it's a clinic specific rate. So every organization will get their own special rate because of what Andy had produced in the chat about how CCBHCs are designed to meet their community needs. There will be different levels of service that some agencies provide based on where they are situated in our state. However, there is still a foundational core set of services that every single CCBHC in the state will offer as a part of their model.
Thank you. And there was a question about, and I think this goes to KBH, have you considered using volunteer physicians as part of the recovery team?
I certainly would. I use volunteer recovery coaches. We've had volunteer clinicians, but we certainly would look at that and see how it fit. I mean, we've been very fortunate, I would say, at KBH to have local physicians who stepped up. I just give a shout out to Gus Stringo's, Audie Horn, physician assistant. If it hadn't been for them, I would not have probably been able to move forward with the OHH in the way that we've had. That relationship with local providers that prescribe has been really important. Big commitment to our community, and shout out to them all that have worked on our team. They're very important partners. So if you know somebody, send them my way.
There was another question. Any ideas for recruiting staff? I realize it's difficult, but wasn't, whether or not you guys had a strategy. And one of the things that I will say is CCBHC does offer some flexibilities when it comes to sort of recruitment and retention. And I think, from a state perspective, as we're looking at creating some efficiencies within the model for reporting, approval of services, et cetera, it lets people really focus more on the care that they want to provide. So I'll then turn it over to you guys if you wanted to talk about any strategies KBH has.
Well, I think we use the ones that everyone's using. We do the whole thing. Everyone knows the sign-on bonus, really trying to be flexible scheduling, everything that people are looking for in the world of our work now to care for themselves. But here's the big one. They go into this work because they want to be able to make a difference in someone's life. And I think that it's models like this and teaming like this, that you're not in it alone, and that this is good work and you can yourself stay strong, resilient, and healthy in it with the right supports, has been a conversation that we've trying to have more and more with new providers or providers who have been in the field for a while and not sure if they want to be there. Because I don't think we can magically make more people to come onto the workforce, but we certainly can enhance the sense of being in the workforce as being a very positive place to really kind of live out your calling of why you probably went into the field. So we're really trying to change the conversation with people. That's been an important strategy, but all the other things, you have to throw all those things in, is figuring out how to make it desirable to do this work. A good wage, good sign-on, flexibility, good benefits, and KBH has been really kind of stood behind us at the front lines, trying to support us and making sure we can offer a good workplace for people to come to. And then our job is to help them stay good, strong, and healthy in it.
I just echo, I think the thing about team-based care, we're all right, we're working team-based care, we're all doing our best to do team-based care, but this is really about breaking down the silos to have really true, a different way of doing team-based care together than we've been funded to do. And so I think that's a huge, that's part of the transformational shift and the draw that Pat said it much more eloquently than I am.
Thank you all.
I
go
did see a
ahead.
couple of questions. Yes, we want to try pet therapy. We think it's a great idea. And working fields, I don't know what that is, but you have my email there. I'd love to hear more. A couple of questions.
Thank you so much, Pat. We'll go through any that were not already answered afterwards. And thank you so much to KBH for joining. And then Madison, I'll hand it back over to you. Thank you for giving us or holding this space for us to talk about CCBHC.
Yeah, no, absolutely. Just want to thank you all of our presenters today for taking the time to prepare for this webinar and to participate in this webinar, and all the folks that have joined us and participating today and in the previous months and in the future. We look forward to seeing everyone at the summit this July. So hope everyone has a wonderful Friday. Thank you so much. Take care.